Thank you very much indeed to the IESS for the invitation. It's a great privilege to be able to be over here and talking a bit about some of our work in the United Kingdom. And it's nice to see a good audience as well. I mean, when I first started this work in talking about measurement of outcomes and that sort of thing, back in the 1990s, it was a while ago, there was no interest in it at all. I went to a meeting in the north of England and only one doctor came to the meeting, so it was very depressing. He said, well, give your talk anyway, so I gave my talk, and I was about to go afterwards after he'd asked a question. And he said, don't go, I'm the second speaker. So, you know, I'm rather pleased to see a good audience here today. Thank you very much for being here. So this is my agenda. I'm first of all going to quickly go through the context for our work in the UK, which is about the private healthcare sector only, the independent sector as we call it in the United Kingdom. Then I'm going to talk about patient information and data in the United Kingdom, and then the role of my organisation, the Private Healthcare Information Network, which I sort of call PHIN, so you know what I'm talking about, and then our progress in addressing that agenda, and just finally some of the challenges that we're facing. So first of all, something on the private sector. As I think many of you know, this is the G7 countries. There are many other ways of looking at this, but I think you can see from here that the British United Kingdom, this is the public spending on the National Health Service. So of all those countries, we spend more on our National Health Service, public money, and this remaining area is for the private sector. So quite a small private sector in healthcare in the United Kingdom compared to those other countries. Just to go through this very quickly, all citizens in the United Kingdom are entitled to the National Health Service, the public system. Everybody, even if they have private cover, they're entitled to the National Health Service. So it's supplementary, it's in addition to the National Health Service. A very small international market. Some patients come from other countries, but mainly we're dealing with British citizens. And the private sector is almost all secondary care, quite small private hospitals dealing with cold elective surgery, and I'll come back to that in a minute. So about 10% of the population buy health insurance, and an additional 3% will pay for their own care separately with their own money, if you like. So the National Health Service therefore dominates the the healthcare system in the UK, and it's funded entirely by taxation. Very little coming from other areas, some money from prescription charges, and it provides a comprehensive care covers every aspect of healthcare. On the other hand, the private healthcare system, as I say, is mainly planned surgery, cold elective surgery. There is a small mental health area in the private sector, nursing homes, and very small amount of primary care. The area I'm particularly going to be talking about today, though, is this area of the hospitals. Just to go into it, just to demonstrate the numbers here, this blue box represents the 85% of patients who are funded and treated by the National Health Service. This box is, some NHS hospitals have a private wing. You can go into a National Health Service hospital and they have a private ward or a private wing where they will charge private patients, a very small percentage. And then in the private sector itself, there is quite a few patients who are funded by the National Health Service in private hospitals. We have a big waiting list problem, and one of the ways that they bring down the waiting lists in the public service is to contract with private hospitals to deal with those patients. That's about 4.4%. And then the main privately funded independent hospitals who are dealing with private patients, insured or elsewhere, is that other part of the box. So that's the group provided by the private hospitals there, and that's the funded ones. So The private episodes are very much delivered to National Health Service patients, so all patients who come into the private sector are also covered by the National Health Service. They're often referred by the National Health Service general practitioner or primary care doctor, and after their surgical treatment they go back into the NHS. And the number of these are the private hospitals in the UK. As you can see, the great majority are in England, 65, difficult to see, in London, the Greater London area, and small numbers in Scotland, Northern Ireland, and in Wales. And actually, these are the units in the National Health Service, the private units I talked about. These are very small, sometimes only 10 patients, 15 patients in one ward of the hospital. The main private hospitals are these ones, and then we're also looking at all the clinics and hospitals which do cosmetic surgery. That's another story. So just to finish this bit on the private sector, the most common surgeries where people go private, as I said, it's cold elective surgery. Cataracts, hernia, you know, these are the things that we tend to see most commonly: knee replacement, hip replacement, shoulder surgery. So that's the context that I'm going to talk about, the nature of the, and finally, why do people buy private care when they have the entitlement to the National Health Service? It's mainly about fast access to health care. They don't have to wait so long for treatment. They can get quicker treatment usually. They will always be seen by a specialist. In the National Health Service, they will sometimes be seen by trainee doctors. They can be quite senior trainee doctors, but could be seen by a trainee doctor. Only specialists will see them in the private sector. And the facilities are generally better in the smaller private hospitals, which have I think I would argue, a better customer focus in terms of the service that they provide. Okay. What's happening with data and information in the healthcare system in the UK? Transparency has been a big issue in the National Health Service for some time now. And actually, the National Health Service is really quite good now at providing information to help patients make choices. In fact, there is an online system called NHS Choices, where patients can go online and they can look up their local hospital and see what facilities it has and what their doctors do and all those things, which is actually a very good system, and it is widely used. So that's what they're doing. But the private sector has not been so good at this. And, you know, the argument about transparency and information is very clear. Our own Prime Minister, David Cameron, said information is power. By sharing it, we can deliver modern, personalised, sustainable public services. And many people have argued about the importance of transparency in healthcare. KPMG definition here, which comes from a big document they did called Through the Looking Glass in 2017. A health system that provides useful, accessible, reliable and up-to-date information to all interested stakeholders so that they can acquire meaningful understanding of the quality, patient experience, finance, governance and individual data associated with the healthcare system. It has to be open to all the patients, and their referring doctors should have access to information to help them make informed choices about their care. And as I said earlier, the private sector has historically been very bad at providing information. Private hospitals are divided into groups, and each group will measure its data in a different way. Some of them will publish some of it, some of them will publish more. Different hospitals will publish different things. Completely impossible for patients to understand the difference or to compare hospitals with one hospital with another. And it's not been independently assessed. So they've been able, basically their marketing departments have generally put the data up, I think, perhaps rather than the doctors involved. And there is a lot of cynicism being expressed about the private sector. So we recognized this problem at the Private Healthcare Information Network. We were founded in 2012, and a group of the large groups of independent, there are 5 main groups of independent hospitals in the United Kingdom, and they came together believing that we should do something about transparency. But there were very big problems, commercial problems between them. Some didn't want to publish some things, some didn't want to make changes, and it was very difficult to get anywhere. And it was going to be relying entirely on voluntary submission of data. So, so these were the issues: cost. Would the adopters be, would the early people who started publishing information, would they be published because they had put theirs out there and nobody else had put theirs out there? Whose methodology was going to be best? All those issues you can imagine came up from the doctors and the hospitals themselves. So in short, driving change required a legal basis. It wasn't going to happen without some legal aspect being taken. And I've been trying to persuade the minister and the medical director of the National Health Service for many years that the private hospital data should be included in the data collected by the National Health Service. But he said it would require legislation and there wasn't time and it was too difficult. And so we weren't really getting anywhere with that. And then we have our Competition and Markets Authority comes along. The Competition Commission in the UK looks at competition issues not only in healthcare but in power, in transport, in the banks, and it decided to look at competition in the private health sector. And they look at where competition is not, you don't get proper competition. And they produced a report in 2014 which mandated, required all the private hospitals to submit data, to get a standardized data set, to improve their collection, to publish performance measures, as you can see there, publication of fees as well, individual doctor fees to be published on this website. And they specified that the organization that was to collect all this data was my organization, the Private Healthcare Information Network. So a major change. They have a legal mandate. If the Competition Commission says you have to do it, you have to do it. And suddenly all private hospitals, all the NHS, private patient units, the cosmetic clinics, all had to start thinking about how they were going to do this. These are the legal obligations that it laid out. We had a duty in PHIN to collect data from all providers, as I've said, to publish measures on our website, to make it available for the public at large so that everybody could look not only at individual hospital data, but individual doctor, specialist data, and next year their fees, their individual fees that they're going to charge for the work that they do in private healthcare. So a major, major task if you think about it. PHIN itself is a not-for-profit, independent organization. Patients are our core focus, as it says there. And we're funded by mandatory. Every one of those hospitals and clinics is required to pay a subscription, if you like, to us, depending on their number of patients they see every year, to pay for that. And the Competition Commission has come down. About 12 hospitals decided they weren't very keen to pay, and the Competition Commission has already taken out legal orders to make them pay. They have the power to do that. And so that's PHIN. So our role, what are we doing to actually, what are we collecting, what's our plan in terms of all this? And the Competition Commission specified 11 performance measures for private hospitals. To be fair, I and my colleagues at PHIN had some input to that to help them decide on what they should be collecting. And of course, the first thing, of course, is activity. As we heard earlier on, the denominator is very important. How many admissions per year are we measuring against when we look at the other things? So activity, how much each hospital, each doctor is doing, very important. The length of stay, of course, is always important. Things that you've heard about this morning, like infection rates, readmission rates for joint replacements, revision rates, mortality rates, of course. Unplanned transfers. Sometimes patients are admitted to a UK private hospital who are more ill they shouldn't have been treated in that hospital, and we have to transfer them as an emergency into an NHS intensive care unit. That's a failure, and we should be measuring those. Obviously, we're collecting data on patient feedback and satisfaction. Part of that is promoter scores, as you heard earlier on this morning. Would you recommend this hospital, this doctor to friends? We're also generating data from the national clinical audits that are done. There's a big national audit for the whole healthcare system on joint registration, the National Joint Registry, which tells you about all the joint replacements that are done in the UK, and we collect data from that. PROMs, patient-reported outcomes, I'm going to talk to you about it in a minute. In our last talk, Dr. Ferreira, I don't know if he's still here, was talking about what they're planning to do in looking at the outcome of patients beyond the safety measures that we've generally been talking about this morning, and of course adverse events. So these are the measures that hospitals have to submit to us, and we've had a big negotiation with them for the standard definitions to get a standardized approach so that we're all using the same definitions for the first time. A huge task. Our regulator, the Care Quality Commission, has 5 main measures that it measures quality, for its accreditation, that it collects data on. Safety, of course. Effectiveness, is the work being done by that hospital effective? Is it caring? Is it responsive? And is it well led? And as you can see in this initial phase of our work, we're concentrating mainly on safety and effectiveness of treatment. The patient feedback will give us some idea on some of those other issues. So those are how we're fitting in. And of course, the Care Quality Commission is very interested in collecting the data from us for their own inspections that they do to accredit hospitals. Hospitals have to be accredited by the CQC in the UK to operate. So, as I say, it's standardizing and one of the problems was that every hospital collected and coded information in different ways. So now every private hospital has to collect the NHS number so that we can link data to the NHS data sets. The GMC number, the General Medical Council number, is so that we can get the number for every doctor working in the private sector and link their records to that doctor. And we're using OPCS procedure coding and ICD-10 diagnostic coding. And a lot of hospitals weren't using that. They were using a different system working with the insurers. So you can imagine the workload, the amount of change which has been required to be able to operate this, which wouldn't have happened but for the Competition Commission. The data comes from various places. I've already mentioned the registries and audits, which is us publishing existing data, which is very hard to get hold of generally for patients because it's in sort of registries which are run by the medical profession, but we're going to be able to share the data in those registries onto our website. Obviously, adverse events and things like that we're collecting mainly directly from hospitals. The hospitals are providing that data for us. The doctors who work in those hospitals, their data will be submitted by the hospital on their behalf. So there are going to be some issues there, which I'll come back to in a minute. And then these new measures, like GMC numbers and things like that, are what enable us to access the NHS data set to see what's happening to patients who have maybe left a private hospital and gone maybe into an NHS hospital at a later date. So quite a complex sort of operation. I want now just to talk about patient-reported outcome measures, which we heard a bit about right at the end of the last talk. I first started getting involved in outcome measures, patient-reported outcome measures, many years ago in the 1990s. And I absolutely passionately, I was saying this at lunch, believe in the safety agenda and the need for improving our safety and reducing our adverse events. And you've seen in the data that I showed you that we're going to be collecting all the data you'd normally expect, which are to do with safety, adverse incidents, infection rates, reoperations, all those things, and mortality. But they are all about reducing failure. They are all about reducing failure. They're not about driving success. They're trying to reduce failure, which is very important, and we learn a lot from that. And I just want to illustrate this by painting this chart. Now, it's a complicated chart. Each one of these is one of our Bupa private hospitals. When I was the medical director at Bupa, so we had about 35 hospitals. The red line is the mortality rates. They're very low because we're doing cold elective surgery, so you would expect that. But I've shown for illustration the reoperations, these green lines here, and I've also shown the emergency transfers out of the hospital, which are measures where the hospital didn't select the patient properly. And it shows you that maybe there's some learning to get from these data. You know, you see variation here. This hospital maybe has a high reoperation rate. We could ask questions about that. But what does it actually tell you about the overall care? Because when I point out that this represents 1% of all the patient episodes in 1 year, this chart, and I show you the next chart, which represents 100% of all the patients. So this is all the patients treated in a year, and this is these adverse incidents and things like that along at the bottom. What do we know about the patients who didn't have a problem? You know, the 95% who didn't actually have a problem. Do we collect data on them? Do you collect data on them routinely? Hardly anybody collects data on them routinely, and yet that is what the purpose of our healthcare organizations is, to deliver reduction of pain and suffering, to try and improve their health and quality of life. Do we measure that? We don't. We're so passionate about safety, which we need to be, because the data on adverse incidents is very serious and we have to reduce that. All I'm saying is that there is another element, quite an important element, for those that don't have a problem, which I think this illustrates quite nicely. So the program that I started in the Bupa hospitals in the 90s, I then persuaded the government to set up a national program for collecting patient-reported outcome measures in the beginning of the turn of the century. And these measures are patient-reported outcome measures. You do a survey prior to surgery. We're talking about surgery at the moment. Immediately prior to surgery, and then 3 months or 6 months later, you send the same form to them and ask them to fill it in again, and you measure the difference. So it's like quality of life, health status survey. So you have a baseline pre-operatively, and then 3 months or 6 months later, particularly for orthopedics, 6 months later, you can then see the difference between the before and after, which shows you your outcome. And I can tell you this is a much more positive chart generally, because most people have a good outcome. And it's but the struggle I had, even persuading our Prime Minister, Tony Blair, that they should do this, because he just thought it would be another stick to beat him with, he said, and because, you know, and I said to him, the trouble is all the data we collect in healthcare is about failure. All we've got is to show we're reducing failure, whereas this shows how much we're improving healthcare. And so the 4 pilot proms that we did in the National Health Service, and it was across the whole NHS for all patients having hip replacement, knee replacement, varicose vein surgery, and groin hernia repair. And it's a very big exercise, and it started in 2009, and you can imagine there are hundreds of thousands of bits of data from all the patients that have been having these operations. And we chose those procedures because they were high volume. You need to have high volume, obviously, to get valid data. And they were a big cost to the National Health Service. This is why we chose those things. And this is just an illustration of the outcome figures that we've seen. And let me just explain this chart. This line here is the sort of no change. Everything hit onto the right, and the light blue is improvement. This blue is no change, and this is got worse. And this is groin hernia, hip replacement with different measures, different survey tools, knee replacement, and varicose vein surgery. So you can see that hip replacement and to some extent knee replacement, the patients, 89% are saying that they gained a benefit from, and you can measure the amount of benefit, obviously. And the Oxford Hip Score, which is specific for hip talks about movement and all the rest of it, 96% and 93, 94% showed improvement with the Oxford knee score. Some people showed a deterioration, you know, but by and large, it was showed very great health gain. Hernia repair, actually, only about 50% of people showed a benefit from patients. This is patients' views, which was very interesting. And in fact, the Royal College of Surgeons decided, actually, we probably don't need to do as much hernia repair as we have been doing in the past for various reasons. So this is the global data for the National Health Service. We can break that down by hospital and by individual doctor as well. They aren't publishing by individual doctor because they promised doctors, they don't want to frighten the doctors too early in this program. But this shows you, and this is very valid, the confidence intervals are absolutely tight because of the huge volumes of patients who are filling in this data. What this data can do is help you to understand a comparison between alternative treatments, maybe with hip replacements, with different prostheses, or whatever it is. You can also then look at the comparison between hospitals, between individual doctors. You can look over time at trends. Are things improving? Interestingly, the data I've just shown you, when it comes down to hospital level, the doctors are very competitive. They don't like their hospital being below the mean, so they try to improve what their hospital's position is in the scoring. And also there is a prioritization. To some extent, the hernia repair, the last one there, about prioritizing in the face of limited resources, the varicose veins and hernia ones, quite a lot of discussion on the back of this data as to whether this was important treatment and are we doing the right things for patients in offering some of that surgery. Back to PHIN and what we're doing. So as you can imagine, with my own interest in patient-reported outcome measures, we are doing a number of patient-reported outcome measures. As you can see here, I mean, we're obviously doing the hip and knee replacement that the NHS is doing, but we're also doing shoulder surgery, carpal tunnel syndrome, partly because lots of different types of surgeons do plastic surgeons, general surgeons, orthopedic surgeons. It's a good general operation to have a look at. TURP, that's transurethral prostate surgery, cataract, septoplasty, ear, nose and throat, and cosmetic procedures. There's been a big debate in the United Kingdom about the lack of openness and transparency in cosmetic surgery, and I, again, was very involved in that debate, and I argued that cosmetic surgeons should be showing their outcomes to help people make choices about their outcomes. And we are using there an American series, which you may have heard of, called the Q-proms. I don't know if you've heard about them, but they're widely in use in the United States. They're very good survey tools to measure things like facelifts, breast operations, that sort of thing. And so those are the ones we're going to be using. So a big lot of data collection. So our two main products, to come back to how it's working, we have a public website for patients, and we have an online portal. This online portal is a private portal for hospitals and doctors, which they can come onto to check their data. If we just publish the data without checking with them first, there'd be a furore, because data collection is very poor everywhere, I'm sure you generally. So we're saying to doctors, we have this data, we want you to come online privately to check whether you think it's accurate or not. We've had a lot of feedback, a lot of inaccuracy, which we've been dealing with. At the moment, we're only dealing with about 5,000 or 6,000 consultants. I mean, about 14,000 doctors actually do private work, but we're dealing mainly with the high volume ones to start with. So they have a chance to come along and check their data, and we've promised them at the moment that we won't publish their data until they have signed it off to get the support from the doctors. But the Competition Commission has said they have to publish that data, and I think at some time they may say, you've got to publish it. But at the moment, we're able to make sure that people are coming online first before we put the evidence on the public website. and our progress in doing this. This is just an example. You can't see the detail of it, of what a consultant, what a doctor would find on their database for their hospital. Some consultants work in more than one private hospital. They may do operations in 3 private hospitals. So we're having to collect all the data from all the hospitals they work in here. So this is the activity by hospital, the number of operations they do, 3 hospitals, this one. This is the activity by the insurer, because there are different insurers working things. And activity by NHS code. This shows the number of operations that they've coded to have been done and the different types of procedures. So they can come on and look at that and check that how accurate it is before we publish it. And there's quite a lot of data already that we can see. If you remember the chart that I showed you before, which is, this is the NHS patients. These are the patients who are treated privately in an NHS hospital. These are the patients who are funded by the NHS in a private hospital, and these are the main private hospitals. And that's the volumes of data. And those volumes are actually different to the ones I showed you in the earlier boxes, because this is absolutely up to date. And there's been a bit of a contraction in the private healthcare sector over the last little while, and that's demonstrated here. We've got the real data, not the data that they volunteer to give, the various agencies. And what you can see here is the breakdown of that, of the different operations. This is just an example of what you can see. So this is the National Health Service. This is the standard private hospitals, and you can see here that orthopedics, the orange is very big in the private hospitals. The green here is ophthalmology, mainly cataracts. So you can get a breakdown of the different types of operations which are being done in these hospitals and get a sense of the variable nature of the work being done in different hospitals, and then you can break that down even more by doctor in each hospital. This chart, which you certainly can't see, just shows the data we collect from the NHS patients who come into private hospitals, the self-pay patients who pay their own way, and the insured patients. Now, this colour is cataract, which you can see we do a lot of, especially in the NHS as well. This is female, this is male. The red is the self-pay. This is breast enlargement, which can only be done in the self-pay sector. Insurers don't pay for that, and nor do the National Health Service for cosmetic breast enlargement. So you can begin to see there the different categories of procedures which are being done and their volumes, which is very interesting. And as we get more into it, we'll be able to break that down by hospital, by doctor. So we're going to have a very interesting data set to put on the website. At the moment, about 344 hospitals are submitting their data. Some have been very slow because of all the work they've had to do it. And this is the nature of the hospitals, about 344, which is the main. They are covering 90% of the private care in the country. So we've got really good take-up now, particularly because we've also had pressure from the Competition Commission to help us. So even though we're only in the first 2 or 3 parts of our data set, we've already got quite a lot of data which is of value to customers, to patients. They can look at the scale of activity, the number of operations done of this particular type or that type in a hospital or by an individual doctor, and they can look at it by specialty. You know, so there's quite a lot of information already available on the website for the public. You can understand the private activity in one hospital. So here is one hospital, and this shows the breakdown of the activity in this particular hospital: chemotherapy, and then gastroscopy and colposcopy, a lot of oscopies, coming down to arthroscopies, and down to the bigger operations lower down. So this again gives you or the customer or the patient an idea of what that hospital does, what it does most of, which is of interest. We're very careful about interpreting that. You can't say that just because they do a lot of them, they're very good at them. You know, not necessarily, although I think most of us would say we'd rather go to a doctor who's doing 100 a year at least rather than 5. But we have to be careful in the interpretation of this sort of data. And you can also look at a different procedure. So this, for instance, is a breast reconstruction for cancer. So this is cancer breast reconstruction, which is very different to cosmetic reconstruction. And so the biggest operator of this is an NHS hospital, a big cancer hospital in the National Health Service, and then some private hospitals underneath it. So you can see there who are the people who are doing most of your particular operation and how near the nearest one might be for you if you want to go to that sort of hospital. So the next steps for us, we have to encourage the doctors of being even slower to engage. A lot of them proclaim that they don't even know about all this, although we have written, and everybody has written to them and told them they have to engage. The Competition Commission has told them. You can imagine doctors are not very keen. Some of them, the good doctors, or the ones who believe they're good, are very happy to put their data out on the site. But people who are more nervous are more worried about it. They don't like the concept, but they have to do it because of the legal requirement. And so I think we will see some changes in practice. Some doctors who are generally doing hip and knee replacements might now not do back surgery in the private sector because they'll realize that their outcomes, because they only do 2 or 3 a year, we're already seeing some changes along those lines. And so I think we need to get that data in. Next April, coming up soon actually, they are going to have to put their fees on the website as well. And this is very controversial. How do you put your fees as a consultant? Do you have a rack rate like a hotel? So it's whatever it is, £800 for a cataract operation. But you know, you get a discount for volume or whatever it is, or do you do an hourly rate? We're having all that discussion with the profession just now, but there has to be a standard way that we're going to have to agree with the medical profession so that everybody is putting on fair fee levels for individual doctors. So it's going to be very radical. This has never happened, as far as I know, in our country, that doctors have had to publish their fees and everybody will have to do it. And it's a huge job for us as well to validate some of that. And then we've got these more qualitative measures coming through, the infections and adverse events, which are really important and we need to work on. And of course the outcome data. The collection of outcome data has already started, but it's too early to show it yet because we have to wait 3 or 6 months before we get the outcome figure, the 0 to 3 months, the 6 months. So that'll be coming soon. We'll begin to show the outcome data which is being collected by hospitals. And what we have done, though, is now got alignment between the private and the National Health Service standards. So we can now use our data to compare with what is going on in the National Health Service. It aligns, and we're bringing together those data sets so that for a doctor, we can bring together all the data for all their work, their National Health Service work and their private hospital work. So 3 private hospitals, their NHS work, so that they can look at all their data for a year, which they need for accreditation with the General Medical Council. Every year now they have to have an appraisal where they have to submit their data to an appraiser for the regulator, the professional regulator, and we are going to be able to help them with that and show them the number of complaints and adverse incidents and that sort of thing. So, and the challenges. Well, these are the challenges that you will face if you try and bring that up into this in this country. There is a need either for government support, strong government to say to the medical profession. Governments don't like telling the medical profession what to do, and the profession don't like being told what to do. But it's very difficult when the Competition Commission comes in and does it, and you need a legal basis if you're going to succeed in doing this in more than a voluntary way. A lot of this is happening in the United States, but it's not applied across the whole system. You get good systems which are doing it, which you heard about earlier on. Obviously, it has to be resourced, and that means that the sector itself will have to pay for it. After all, they are the ones that are going to be presenting their data to customers. It's in their interests to get the data valid, and if they're good, that will be really important because people will come to them. So there's a big incentive to be putting your data out there and showing that you're a leader in getting your data out there first, and demonstrating for the market, you know, what sort of work you do. Big issues that we've had with privacy and information governance. Everybody's having these issues. We've got a thing called GDPR in Europe, which is laying down the rules about data collection, and we've had to fit in with all that in order to link up to the public National Health Service database. And you know, although the professional bodies and the doctors have been told you have to do this, doctors don't like being told, and we've done a huge amount of work in engaging the doctors, encouraging them, showing them that the data can be valid if they come onto the site. And that has taken a lot of our time, has been getting them to buy into the process so that they don't just say it's all rubbish. And so we have to do case mix adjustment, and we have to collect quite a lot of data, which enables us to do case mix adjustment as well if we're going to produce data which the profession will buy into. So that's me there. No, it isn't. So I'm very happy at any time if any of you are interested in this work. Do make